Hello, my name is Jennifer Stransko, and I am the Physician Engagement Associate for MAVEN Project. Thank you all for joining us today, and our friends at El Rio FNP Residence for hosting today's session, Erectile Dysfunction, Evaluation and Treatment, More Than Just a Pill, with Dr. Kenneth Snow. Kenneth Snow, MD, is Chief Scientific Officer for Sequel MedTech, a maker of an automated insulin delivery device. Prior to that, he served as Medical Director at Insulet Corporation, a maker of insulin pumps, and as a medical director for clinical strategy in the medical affairs division of CVS Health. Previously, Dr. Snow was on the staff of the Joslin Diabetes Center in Boston for 19 years, including 5 years as chief of the adult diabetes section. In addition, he was an assistant professor of clinical medicine at Harvard Medical School. And whenever you're ready, Dr. Snow, you can begin sharing your slides.
Great. Let's see. Are they not sharing? Okay.
We can see them.
Okay, good. So thank you everyone for joining today as we talk about erectile dysfunction, the evaluation and treatment. And I'm an employee of Sequel MedTech, but otherwise I have really nothing else to declare at this point. And do not want to hear about my introduction because Jennifer just did a very flattering job of introducing me, so thank you. The goals for today, let's get right into it. What do we want to get out of today's talk? One is to develop an approach to diagnosing erectile dysfunction. 2 is to review available therapies for ED. And then 3 is to understand the limitations of the therapies. What can we expect from the therapies that are available, and what do we need to talk to our patients about to make sure they understand that they should not have unrealistic expectations. And to start this is, why are we even concerned with this problem? And there's a number of reasons why we want to address this with our patients. The first is that it does affect quality of life. It influences the general health perception among men. It is certainly an unmet medical need. And it can reveal other common disorders that primary care clinicians frequently or routinely treat. Hypertension, dyslipidemia, diabetes, major depression, all of these may manifest themselves as a complaint regarding erectile dysfunction. So how do you start the talk or this question? And there's any number of ways to do this, so I don't want to be overly prescriptive, but if you're looking for a way to like, how do I bring this up? This can be simply a review of systems, how are you feeling, and just many men with your medical condition experience sexual problems. Has this happened to you? So somebody comes in, they're being seen for their hypertension or their diabetes or what have you, can lead just as this part of the routine question. This is very reassuring to the patient that other men have this condition, so they shouldn't be embarrassed about it, that it's a medical condition, and hence they should feel comfortable or at least willing to talk to you about this. There's any number of ways to classify male sexual dysfunction, and it's important to walk through these. Not that we want to do a deep dive into all of them, because that would be a symposia, but rather just understanding ways that these can break out. And we can think about male sexual dysfunction as disorders of libido, diminished or excess sexual interest. There's disorders of erection, erectile dysfunction, prolonged erection, erectile deformities. We'll be coming back to this, particularly about ED as the majority of the talk. There's disorders of ejaculation and orgasm, either premature ejaculation or delayed or anejaculation, retrograde ejaculation, anorgasmia, and then the disorders of pain, such as Peyronie's disease or chronic pelvic pain syndrome. And it's important that as you ask folks questions, that you keep in mind that men can have issues with any number of these or multiple complaints from different categories here. And so if we're talking about erectile dysfunction, that you need to make sure that that the patient is aware that that's what you're talking about. If they're raising an issue about something else, you need to make sure that, that you're not thinking about treatments for ED when really their problem is, let's say, chronic pain or retrograde ejaculation or anorgasmia. Now, ED is associated with numerous risk factors, age being the most potent. So men over the age of 70 have an increased risk of sixfold, but a number of other medical conditions, diabetes, age being in the 60s, hypertension, depression, less educated men, that's in association with ED, and unemployment, and as well as lower urinary tract syndrome complaints, so non-specific complaints. There's also an increased risk that there's an underlying ED problem. How common is it? ED is very common. And depending on severity, whether we think about this as minimal, moderate, or complete erectile dysfunction, as men get older, this becomes quite common. And so, as you can see, well over 60% of men will have some degree of erectile dysfunction by the age of 70. This data comes from the Mass Male Aging Study. But still, even men in their 40s, there can be some degree of ED complaint, in up to 40% of the population. So I mentioned that there's a lot of overlap with other conditions, and that's certainly not by accident. It relates to the underlying common pathways involved in them. So we know that disorders such as diabetes, hypertension, hyperlipidemia, and we can throw in tobacco use for that matter as well. All of these lead to oxidative stress, which lead to endothelial cell dysfunction. And this manifests in the case of diabetes, hypertension, dyslipidemia, and tobacco in ways that we are quite familiar with: atherosclerotic disease, thrombosis, vasoconstricted disease. But this endothelial cell injury also leads to erectile dysfunction. So it's not surprising that these same conditions, dyslipidemia, diabetes, hypertension, smoking, share in common an outcome that's also erectile dysfunction. So, how do you approach the patient who has EDs or ED, and how do you evaluate this patient? So, a basic evaluation of sexual dysfunction, sexual, medical, psychosocial history. So you want to make sure that you know what you're talking about. So particularly with the sexual history, you want to make sure that the complaint they're complaining about is erectile dysfunction, as I mentioned before. A focused physical exam. So this can be quite limited. You want to do a general exam to see any signs of abnormalities, Peyronie's disease, fibrosis, vascular insufficiency, testicular exam looking for small testes. So a very limited exam necessary for the ED. Obviously, if they have other conditions such as diabetes, you want to make sure that you're thinking about the exam for that as well. But the exam for just ED is a very focused exam. And then some recommended diagnostic testing if they have not already been done. Glucose lipid profile, again, for this obvious reason. Serum chemistries, basic LFTs, creatinine, and a CBC and a testosterone, preferably morning. It doesn't have to be fasting, by the way, but it has to be morning. Empiric trials of therapy are discouraged without this basic evaluation. So I know that there can be a tendency sometimes somebody will complain of erectile dysfunction, and they often will ask, hey, can I get one of those pills? Without examining them, really discourage this, because first of all, this may not be the major problem that they have. And second of all, they may have another problem that's the cause of their ED that you really want to identify. So you really want to do this basic evaluation, which much of it you've probably already done as part of exam for other purposes. But if not, or those parts that haven't, you want to make sure that you add it. We'll assume that you do the evaluation and it drives you that we're talking about a problem of erectile dysfunction and you're not finding other issues. They're not hypogonadal. They don't have significant vascular insufficiency, that there's not another issue going on, and you're thinking about treating this patient. So kind of the common ED diagnosis, and then what am I going to do about it? And one of the first things is to think about cardiac risk. And the reason is, if you're about to treat them, they are about to begin sexual activity. They are about to begin an exercise they have not been participating in. And so like any patient, if they came in and said, hey, doc, I want to start a new exercise regimen, one of the first thoughts that would go through, I think, everybody's mind for the patient is, well, are they well enough to participate in this form of exercise? Well, what do you want to do? And do they have a cardiac issue? So they've told you what they want to do. They want to be sexually active, and you're thinking about treating them to allow this to happen. So you want to differentiate just where they are in the spectrum of risk: low risk, intermediate risk, high risk. If they are low risk, they can initiate or resume sexual activity or therapy, and you can feel very comfortable initiating therapy for sexual dysfunction. If they are high risk, then obviously you do not want to initiate therapy until after their cardiac issue has been stabilized. So somebody with unstable angina, you would not want to be prescribing therapy of any kind for sexual activity until after they're in a stable cardiac situation. But if they're in that indeterminate risk, you may want to do further evaluation, making sure that, if there's, potential questions regarding possible angina symptoms, do they need to get, a stress test? If they do need to see cardiology, if they need the other cardiac evaluation before feeling comfortable. And that depends on what their past risk is, what their risk factors are, and what kind of concern are raised. So in terms of the ED history, the first question is, what exactly is the problem? And that may seem like an obvious question, but it is a difficult one sometimes to ask, because again, you want to make sure that they say, well, my erection is, has a bend to it. Well, that's, we're not talking about ED, we're talking about, a deformity, and that's a different issue, probably Peyronie's disease. So that's going to be a different approach and different option of therapies than if they say, well, I can't get an erection. How long has this been going on? And was the onset gradual versus sudden? Obviously, when we're thinking about organic endothelial cell damage, usually the duration has been a while. The onset was gradual. It's been worsening, as opposed to something that came on very recently and very acutely, far less likely to be one of these endothelial cell dysfunction as the etiology, but you begin thinking that this could be another etiology. Maybe there's a psychological or situational or a stress going on. Situational, is this all the time? Sometimes? What's the situation where it occurs? Gee, this is worse when I'm tired at night, if I've had a couple of drinks. Or social situation, what's going on at home, what's going on at work, is there stress? Prescriptions, and particularly any new prescriptions, but many medications can obviously lead to erectile dysfunction, or more pertinent, they can take somebody who has minimal erectile dysfunction or moderate degree of erectile dysfunction, of which they were not complaining, but made it worse. And now it's risen to the level that they want to discuss therapy options, because now it's reached that threshold for them. And of course, any other substances that they're taking, tobacco being number one, but alcohol, and also don't forget about nutraceuticals, all that stuff over the counter, because depending on what's in there, there may be stuff that there's going to be a simple solution here is that they shouldn't be taking it. So make sure you ask them specifically about anything over the counter, any kind of nutritional supplements, etc. You can also consider the use of validated diagnostic questionnaires. These can serve a couple of purposes. One, they can complement the history and the physical. Two, they can facilitate open communication. They fill out the questionnaire. You take a look at the questionnaire. Oh, I see you have problems, and that just makes the a much easier conversation to initiate. They can also be used to monitor therapy. So you can compare how they score before therapy and after therapy and see if things are improved. And also, this is, by the way, how efficacy is measured for the various treatments that are available. Two common examples. One is the International Index of Erectile Function, the IIEF. And then the other is the Global Assessment Question. And we'll get to both of these. So the IIEF, it's a widely accepted tool, possesses excellent properties concerning convergence, divergence, discriminatory validity, sensitivity, specificity, all the things you want out of a survey. It's statistically validated, and it's been used in every major trial with oral treatments of ED on the market. So it's a very helpful tool. There's 6 questions that are used in the short form, and they're listed here over the past 4 weeks. How often were you able to get an erection? When you had the erection with sexual stimulation, how often were your erections hard enough to be able to penetrate your partner? When you attempted sexual intercourse, how often were you able to enter your partner? During intercourse, were you able to maintain your erection after penetration? During intercourse, how difficult was it to maintain your erection to completion? And how would you rate your confidence that you could get and keep an erection? And these are scored on a 1 to 5 basis. Nobody wants to get a 0 on any question. So it's scored on 1 to 5, 6 questions. So obviously it's up to, it's between 5 and 30 points. And I will point out that while you can use this questionnaire in male homosexual relationships, it has not been validated in this population. It's only been validated in heterosexual population. In scoring, as I say, it scores from 5 to 30, and normal being over 26, and severe erectile dysfunction being under 10, and graded in between. And so you can rate both in terms of a scale and also whether the issue is mild to moderate, moderate to severe. This allows you to then do follow-up, of course, after testing and see if scores have improved. The other one I mentioned is the global assessment question, which is a very fancy word for basically one sentence. Has the treatment you've been taking over the past 4 weeks improved your erections? So you identify that they've had ED, you treat them, they come back, global assessment, how are they doing? Has it helped? It's the most widely used parameter to measure treatment efficacy. It's obviously extraordinarily simple. It's very easy to interpret. And it provides responder rate information. Did it help? Yes or no? There's some real problems, though, with this because there's a significant bias in terms of patients wanting to answer yes. You note that it doesn't ask degree of improvement. So has this helped? You can imagine the patient sitting there. It's like, well, I came in, I mentioned about this, they gave me a prescription. Is it better? That's a little better. So yes, it helped. If you then ask more probing questions, did it help? A lot. Did it solve your problem? You may get a very different answer, as in, no, it didn't. It didn't really help a lot. It helped a little, and it really didn't solve my problem. Well, that's not really showing efficacy. And it really doesn't give you the kind of discrimination that a survey instrument like the IIEF would give, where if you move from a score of 15 to 23, you know that it's helped a fair amount. I caution the use of this, or at least the use of this as the sole determinant of efficacy. Now, as we move to therapy, we think about at least sort of 5 degrees, or I think about at least 5 degrees of acceptance here. One is the efficacy. If it doesn't really help, that's not really particularly great therapy. Side effects, contraindications, significant issue, depending particularly other medical conditions a patient may have. How easy is it to administer? How invasive is the therapy? And also the patient partner acceptance of the therapy. And so this survey work done on this, and not surprisingly, if you ask folks, ask men about various therapies that are available, pill wins. We know this from popular culture. We know this from market share. Clearly, a pill wins on the questions that I previously mentioned, and it's a pretty dramatic difference between the other options. And so that's how oral therapy tends to be the number one thing that we think about. And so let's talk about that one as number one. So, what the medications, the oral medications that are on the market have in common is that they are all PDE5 inhibitors. And it's like, oh, okay, so a refresher of, well, what does PDE5 actually do that you're inhibiting it? Why does that help? Well, for smooth muscle cells, which is what's driving erectile function, nitric oxide stimulates guanyl cyclase. And what that does is it facilitates cyclic GMP to activate protein G, which then leads to smooth muscle relaxation and the development of an erection. Cyclic GMP is then metabolized to 5' GMP by PDE5. If you inhibit the PDE5, you get more cyclic GMP, so you're going to get more protein kinase G and more smooth muscle relaxation. So it inhibits the metabolism of the cyclic GMP, so that it hangs around longer, so that you have greater smooth muscle relaxation. This is, in addition to understanding the mechanism behind it, there's an important point that comes out of this, which is you're not generating nitric oxide and guanyl cyclase, and hence not generating cyclic GMP, unless if there is sexual stimulation. In younger men, that may just be visual. In older men, that's usually tactile required. And so, the phrase is, well, if you take this pill and you go out and cut the lawn, what you're going to have is a nicely trimmed lawn, but you shouldn't expect an erection. They do not stimulate erection spontaneously. They allow men to achieve an erection. And so men need to understand that, and you should specifically mention that with them, because if you don't, one way that men will do this, and it's kind of understandable, is they'll get the prescription. They'll say, well, before I test this out in sort of, real world situations, so to speak, with their partner, they'll say, well, let me just take this and see what it does, see if I have any side effects and see if it helps. But of course, if they're just sitting there watching TV and they take the pill, and they may not have any side effects, but they are not likely to have any kind of response to the drug either. And they'll say, oh, so it didn't help. So they need to understand that there needs to be sexual stimulation for the pill to facilitate an erection. The 3 drugs that are out there, sildenafil, tadalafil, vardenafil, have different properties in terms of how long it takes for them to be active, when they reach peak efficacy, and then how long the drugs last. And so Viagra, Levitra, much shorter time to Tmax, under an hour. Half-life is much shorter. And so what this means compared to Cialis tadalafil, which has a much longer half-life, but a much longer time to maximal concentration, maximal effect, it means that they need to plan taking the drug accordingly. So Viagra and Levitra are much more on-demand drugs. Cialis is much more something that will be taken in advance so that later on the drug will be in their system. So they want to make sure that they give adequate time for the drug to take effect. It's a minimum of at least 10 minutes, 10 to 20 minutes really for Viagra. Levitra can be an hour to 2 hours as a minimum for Cialis. So they really want to give the drug the fair trial. So what they don't want to do is with either Viagra or Levitra to take the drug and expect that it's going to help in the next 5 minutes. But on the other hand, for something like Cialis, they definitely don't want to take the drug and expect this to be helping anytime in the next half hour. That's a drug that they want to take and wait a few hours and say, oh, well, that may be something that they take in the evening, dinner time, knowing that anytime later that night, and even into the following morning, the drug will be in the system and providing benefit. What about pharmacodynamic interactions? So PDE5 inhibitors, nitrates, and alpha blockers all cause vasodilation through that same mechanism, and they can all decrease blood pressure. Nitrates stimulate cyclic GMP production by delivering nitric oxide. And since PDE5s inhibit the breakdown of cyclic GMP, this leads to vasodilatory properties, and it can cause transient decreases in blood pressure in healthy volunteers. And actually, the combination in young, healthy men, so no medical issues, men in their 20s, that it's pretty tough to get them to be hypotensive, you can see drops of systolic blood pressure of 40 points with this combination. So if you translate that into an older individual whose vascular system is not as robust as a 20-year-old, you can see this can be dramatic. And what you really do not want to do is drop blood pressure in a 50 or 60-year-old and drop their systolic blood pressure to 70 or 80. So this is a significant warning about taking a PDE5 in the presence of somebody who's on a nitrate. Alpha blockers inhibit pressor effects of epinephrine, so this can also lead to a fall in peripheral vascular resistance and venous return, and as such can lead to hypotension. And it's associated with first dose postural hypotension and can actually lead to syncope. And then, of course, taking these in combination increases the risk. So for anybody who's on a nitrate regularly, this is a dangerous combination. For anybody who's on an alpha blocker, they do want to do a test dose to make sure that they don't have significant drop in blood pressure. And they should be warned about it. It's not an absolute contraindication, but it is a warning. So they should just be aware of this for patients who happen to be on either of these classes of drugs. So we know that these drugs can be effective, but they are not effective for everyone, or if they have a contraindication, what other options are available for therapy? And this is really, I think, important to know as you treat people with ED, so that they understand that this is not the only option that's out there. It may be the only option that they wish to try or to choose, but they should be aware that there are other options. They've also probably, if they've spent any time in a car, they have probably heard ads from some local urology or men's health clinic talking about therapy done in the office, and they may very well ask you about these. It's like, well, what did I hear about on the radio? So you should be aware of what's out there and what folks are talking about. So there's intracavernosal injection therapy, and we'll walk through that. There's urethral suppositories that are available that are also the same medication. There's also vacuum constriction devices. And finally, there's implants. So we'll walk through those 4 therapies. And then, of course, there's the option of no therapy, which to me should be an active choice as opposed to a passive, they get offered a pill and then not aware that there are other therapies available to them. If they get offered a pill or they can't take the pills or they take pills and they don't work, and they choose not to use one of the other therapies, and that was a choice they made of what does or doesn't fit in with their lifestyle and what they wish to pursue. But then it's an active choice with the patient as opposed to a choice being made for them because they weren't informed. So we'll take these in order. And we'll start off with intracavernosal injection. And this is, as the graphic shows, it's an injection of a vasodilatory agent into the corpus cavernosum of the penis. One of the things to keep in mind is this is done, the injection is to middle to the base of the penis, not out at the tip. The reason that's very important, other than, of course, proper technique, is that from a sensitivity point of view, lots of pain fibers out at the tip of the penis, very, very few at the base of the penis. Patient needs to understand that this is not going to be particularly painful, no matter how much they think it will be. I will tell you, do not spend too much time trying to convince them that it's not, because you'll lose that argument. They're not going to believe you until you do the first one. All you can do is tell them there's really not a lot of pain fibers. Trust on this one, and let them do the injection, and they'll prove it to themselves. Or you do the injection, or they see the urologist who does the injection, and they'll do the first one, and they will learn that it's not particularly painful. They should just be aware that it's not, but there'll be a lot of skepticism met with that statement. What can be injected? Well, alprostadil is approved. It's a synthetic PGE agent, prostaglandin E1. That's rapidly metabolized. It's useful in treatment. It's also useful in diagnostic testing. This is probably what they're hearing about on the radio, where they say, "I'll come into the office, they'll do the first test injection," right? And the ones I've heard, if it doesn't work, your visit is free. The typical dose is there. It initiates erections across all etiologies. It's 60 to 70%. The efficacy is superior to papaverine or papaverine-phentolamine bimix, which many urologists used to use. So it's highly effective. That's why they can give those kind of combination, why they can give those kind of guarantees. And we'll talk about combination therapy where the efficacy is even higher in a bit, which is why they're willing to give these guarantees. The adverse effects, well, it's local. You can get a prolonged erection. And this is really where those warnings that you hear on the PDE5 pills come from, is really, this is described mostly with intracavernosal injection, where they can get a prolonged erection. And all joking aside, this is extraordinarily painful. It is a medical emergency. So it is something that any man who's undertaking ICI should be aware of and understand where they're going to, how they're going to seek treatment if they're unfortunately to fall into the small number of men where this occurs. And as you can see, it's somewhere between about 1/3 to 4%. They can get fibrosis. There can be some painful sensation, particularly if they have not had erections in a long time, if they've had complete ED and they've not had erections. This tissue is being stretched for the first time in a long time, and so they can get some pain on that. While alprostadil is approved, many urologists will use a trimix where they use papaverine in combination with phentolamine as well as the alprostadil. This is an unapproved therapy. But it's been used for a very long time, and so it is part of the particularly urologist realm of the urologists who treat ED. It is part of their armamentarium. Many of them feel quite comfortable with this combination. It is the most potent ICI therapy for ED. It is superior to alprostadil alone, not surprising, and response to this is as high as 90%. And that's how they can give that guarantee about if your injection in the office is not successful, the visit is free, because they know that that's a 90% likelihood that they're not going to have to give that for free, that it's going to work. They didn't say that they guarantee if you choose to go home with the therapy. What they say is that they guarantee that it will work. The adverse effects, well, if it's more likely to cause an erection, it is more likely to induce priapism and more likely to induce penile fibrosis, and compared to alprostadil alone. So that is one of the great issues of using this therapy. And of course, with any kind of cavernosal injection, whether it's alprostadil alone or with trimix, there's always the danger, since the patient is going to be doing this at home, that if a little bit worked pretty well, a little more is probably going to work better, and a lot more is going to work a lot better. So there's always the concern that the patient will over-inject, that they'll take a greater amount than what they're prescribed. And that can lead to complications, of course. Alprostadil is also available as a medicated suppository that's delivered to the penis. The mechanism of action is the same as alprostadil, injected, but instead of the injection, it's delivered through the urethra and absorbed across the cavernosal tissue. The doses of this are obviously much higher because of less efficacy in terms of delivery. The idea behind it was that for those men who don't want to do an injection, they can avoid that. But for many men, this is also going to be a challenge, or equally challenging as the injection. So its acceptability is relatively low, and the response rates are lower than with the injection therapy. But it can be combined with something such as a constriction band to help prevent blood from flowing out of the penis. So you get vasodilation, the erection, with a constriction band that's going to help prevent outflow. And some men will find that this is adequate therapy. The problems, adverse effects, it's far less likely to induce priapism, but you can get some local penile pain, and you can get a vasovagal response from it. So there is postural hypotension, dizziness, not so much from the drug itself, but from the procedure. And of course, in rare circumstances, it can lead to frank syncope. So again, something to be considered, that man tries this for the first time, either done in the office, or if they do this at home, that they should be sitting down and recognize that this could be a side effect. And so if they do, that they should lie down. The next therapy I wanted to talk about is a vacuum constriction device. These are externally applied device. It mechanically creates penile blood engorgement. It's a cylinder that's placed over the penis. It creates a closed chamber. The bottom of the cylinder is wedged up against the body. It's a closed chamber. There's a vacuum that's created. The vacuum is generated by a pump. The pump, as shown here, could be a mechanical electrical pump that generates the vacuum. It can be a mechanical pump that has a little hand pump associated with it. But either way, the vacuum is created, blood is drawn into the penis, and a constrictive band is then placed at the base of the penis to contain this blood in the penis and maintain the erection. The efficacy is extraordinarily high. It uniformly produces an erection. Reported satisfaction rates are about 55% at 2 years. So even though it works, there's obviously the cumbersomeness that goes with it, that drives down the satisfaction with the therapy. And that gets back to the issues from before of what drives the therapy to be acceptable. The advantage is there's on-demand use. You want the erection? That's when you use the device. There's no waiting. It will be effective as soon as you start using it. There's no systemic side effects. If somebody asks, what's the safest thing I can use? This is it. There's no drug side effects. It's also the most cost effective. Even if they pay cash for it, obviously there's no cost per use. So eventually it pays for itself and there's no ongoing cost. If it's covered by insurance, then it's free. There's no copays that go with this. The disadvantages, number one disadvantage is the obvious. It is cumbersome. A second disadvantage that folks should be aware of is that it's an unnatural erection, and what's meant by that. I don't particularly like that term, but what's meant by that is this is not arterial blood flowing into the penis, but it's actually venous blood that's being drawn into the penis. It's going to be about a degree colder, which some men may notice, but oftentimes will be the partner that notices it. So it's something they should be aware of. This is not a problem. It's just something that they notice. And also because it's venous blood, the penis is going to be much duskier, as you would expect from venous blood. So it is an unnatural erection. Side effects can include petechiae, ecchymosis, so you can get bruising, particularly if it's a mechanical pump and the person's a little aggressive in how fast they inflate it. If they have not had an erection in a while, again, just like with the injections, you can get some penile pain, particularly on stretching of that tissue for the first time in a while. If the ring is on tight, there can be ejaculatory blockage. This is not a problem in terms of health. They'll get retrograde ejaculation, but it's certainly something that they need to be aware of. You can get some numbness. And one danger that they should be aware of is penile hinging. What that is that at the site of the band and distal to the band, the person has an erection. But proximal to that band, at the very base of the penis, they do not. And so they need to just think about this in terms of angles of alignment, because you can get significant hinging effect where the penis will bend. So they need to just keep that in mind, that proximal to that ring or constriction band, they're flaccid. And then finally, there's penile prostheses. These are implanted. They're inserted surgically inside the corpus cavernosa, and they mechanically produce penile rigidity. They can be semi-solid rods, which are malleable, and they manipulate the penis into an erect position, so they have a semi-erect penis always, versus inflatable, which are enclosed cylinders connected to a pump reservoir system that's manipulated for basically hydraulic filling of the cylinders, and they develop the erection that way. The malleable semi-solid, semi-rigid rods are much simpler. There's no moving parts, so nothing's going to go wrong with this. Whereas there is a possibility of technology failure with the inflatable pump, particularly over the course of time. So there is more of an issue there, but it is a more natural erection. So patient has to choose which of the two is more acceptable to them. This is expensive technology. So it usually needs to be something that patients will consider only if they have insurance coverage for it. The efficacy, the benefits of therapy, the efficacy is highly effective regardless of the cause. Success rates anywhere from 85 to 90%. Advantage is it's curative, it's spontaneous, it's there when you want it. The disadvantage is, again, it's an unnatural erection in the sense that you can feel the device. It does require surgery. There are potential complications, either mechanical failure with the inflatable devices, but there can also be infections or erosions. So very uncommon, but very severe complication. It is irreversible. The surgery destroys the cavernosal tissue. So this is not something that it can say, well, what if I try this and if it goes wrong, I have a complication? Well, can then I try something else? The answer is no. So once attempted, this brings them down a path that there's no return from. And then of course the cost. So those are the various options for therapy. And so in summary, ED is common. Screening for ED can be part of a routine evaluation of men's health. PDE5 inhibitors are the most common form of therapies, but just keep in mind that other options do exist if PDE5 inhibitors fail. This does fall usually into urology or a specialized urologist who will deal with these problems. But they don't get to the urologist routinely unless someone mentions that there are other options. And so it's useful to be able to explain to patients that there are other options available if they wish to pursue them. With that, I thank you for the time, and I'll stop sharing and happy to open up for any questions that you may have. And do not be shy, despite the subject.
Well, while we're waiting for some questions, I just want to have a reminder about the CME survey. It'll appear in a tab when you close out of this webinar. So we really appreciate you taking the few minutes to complete this. Not only does it give you the CME credit, but also helps to plan the best session for you. We share the feedback anonymously with the speakers, and they greatly appreciate your thoughts. And I did put some information in the chat about the certificates.
I will mention that some healthcare providers, particularly female healthcare providers, may feel a little uncomfortable, and particularly if they're younger. I've heard this from younger female physicians. They may feel uncomfortable, like it's like talking to my dad. This is not something I really want to do. Are they going to be uncomfortable talking to a younger woman about ED? And the answer actually, at least anecdotally, is no. The men are not uncomfortable, and they feel that there may actually be a bias that they feel more comfortable. Interesting enough, the vacuum assist device companies often have female customer service reps. You would think that would be the worst thing for a company trying to make business, that a woman is going to be answering the phone and answering technology questions for how do I use the device. And yet many men feel more comfortable. So I think the short story, obviously, there's a whole spectrum of what patients feel comfortable and who they feel comfortable with, but do not write off just because you're male or female or younger or older, that somehow that is going to discourage a patient from wanting to talk about this. Any individual, maybe they will in a particular group, but across the board, you don't need to worry about that. So feel free to raise the subject regardless, and there's a good chance that the patients will not only feel comfortable talking about it, but appreciate the fact that as their healthcare provider, that you were willing to raise the question with them.
And we do have a couple questions. At what time should testosterone be tested? Sorry if I missed it. And it's total we check, right?
Yeah. So best to check in the morning. Testosterone levels are highest in the morning. They tend to fall in the afternoon. So if you check in the afternoon and you get a lower level, you're not sure, is that just because it's circadian rhythm and diurnal variation of lower testosterones in the afternoon? So you do want to check in the morning. Almost always a total will be adequate. There are some conditions where if significant malnutrition or the like, where binding proteins are decreased, and as such, free testosterone is a better test to get in those situations. But for the most part, a morning testosterone is going to be adequate to give you the answer that you want.
And again, and if testosterone is low, then check LH.
Right. And if testosterone is low, then the question is at that point, why? Is this primary or secondary? So is this primary testicular failure? Or is this arising from an issue with the pituitary? So check the LH. If the LH is elevated, then you know that it's a primary testicular problem. If the LH is not elevated, then you know that this is primarily central, which when you see hypo low testosterone levels secondary to, let's say, ongoing chronic illness or of aging. So particularly common in diabetes, where you see these testosterone levels that are not profoundly low, but in the 200s. What you usually see is a normal LH with it. You can think of it as an inappropriate response of the pituitary, because in reality, it should be producing more. They don't. So you see, that normal LH level in the setting of a mildly low testosterone level, and you have your answer that there's a secondary issue, a central issue going on, and those can be treated successfully with testosterone if the testosterone levels are low enough. And I see a question regarding for poor patients. What's the most cost-effective form of oral medications to use, like Viagra? Yeah, sildenafil, which is available as a generic, is probably the most cost-effective way to do this. It's not always available in dosages that are adequate to treat ED. So keep in mind that most men need 50 to 100 milligrams of sildenafil. So if they're picking up 20 milligram tablets as a generic, make sure they're taking 3, 4, 5 of them. But it's still usually cheaper than on brand.
And we have a question in the chat. Do these therapies impair orgasm, or can you assume erection equals orgasm satisfaction? And is there a limit to the oral meds in regard to age, i.e., is someone too old for the oral option?
Yeah. So do they impair orgasm? The oral therapies do not impair orgasm. Vacuum assist devices may impair ejaculation, but not orgasm. But keep in mind that just because the person only, complains of one issue, they may have two. So they may complain of erectile dysfunction, but they may have anorgasmia as well. Maybe they don't know it, or maybe they haven't had the opportunity to figure it out, because if they're not having erections and they're not having sexual intercourse, how do they know that they're anorgasmic? So you may be uncovering a second issue by treating them. But the drugs itself won't treat anorgasmia, but it won't cause. Is there an age limit? No, not per se, other than keep in mind that the same risk factors for ED as men get older are the same risk factors for cardiovascular disease. So you may have a very different threshold in terms of cardiac testing for a 75-year-old than you would for a 40-year-old. But if the person's like in great shape and they're like, oh, I jog every day and I'm on my exercise bike or whatever, and you feel comfortable from a cardiac point of view, then there's no age limit. If you have concerns, then the same as you would for concern for somebody who is 55 and that you might evaluate them, you'd have that same concern for 75 and evaluate them, but the age itself is not the driver.
Couple more. Do you feel that endocrine disruptors in our environment can affect testosterone levels?
There certainly is a lot of evidence pointing in that direction. And it's of concern. I mean, clearly testosterone levels in the population in the male population have been falling over time. I mean, that we know. Is this because of environmental issues? It's certainly, there seems to be a relationship. Now, whether it's causal or not has not been proven, but it is of great concern, and they're difficult studies to do, and to reach a level where we're confident of it. So may it be, could it be? It sure could be. It is definitely something to consider. But regardless, we can't necessarily remove everything out of the environment that we'd like to, but we can at least treat the patient for their complaint. So,
And for someone with a history of an MI or cardiovascular disease, is it best to say they be cleared by their cardiologist first?
yes, that was a quick answer. Yes. They have known cardiovascular disease at that point. It has caused a vet. I mean, and unless if you feel really comfortable in terms of the fact that, that were cleared by the cardiologist to exercise and they've been vigorously exercising, in which case the cardiologist is not going to add anything else other than that's really the question you're asking the cardiologist is, can they exercise? But if they've had a cardiovascular event, MI, stent placement, etc., and they have not been routinely exercising recently, then they are starting a new form of exercise or potentially starting a new form, and you want them cleared by their cardiologist.
I don't know if I'll be able to pronounce this word, but is there tachyphylaxis with any of the meds?
Tachyphylaxis, yeah. Do you get used to the drug and need to increase the dose? Not as far as we know, but not as far as we know. But there is, of course, the conditioning, the condition worsening over time. Obviously, aging and what other medical conditions they have that could be that is leading to the problem and to further endothelial damage. So it's not so much tachyphylaxis from the drug, but rather worsening of the underlying condition. And as such, there may be a decrease in efficacy over the course of time.
And then someone asked, will you give examples of environmental endocrine disruptors